of Lateral Think, giving me the nod of approval there, or disapproval.
Or disapproval.
Today we have with us David McCloskey, who in fact is a patient here at Melbourne Athletic Development and whose daughter is a physio that works here at the clinic. And we have David on because he is involved in data analytics, and we're interested to get his perspectives, his experiences, and think about how some of the stuff that he does translates into what we do in healthcare. So to begin with, David, do you want to introduce yourself and give us an idea of who you are and your background?
Look, very happy to, and given my age now, I won't run through everything that I've done, otherwise we'd run out of time here. But I actually started, my professional work as a psychologist and did a lot of work with rats and stats. And I can remember sitting through those lectures and thinking, I will never, ever use this kind of approach in my life. And funnily enough,
you're using it now.
I'm using it now, and it's turned out to actually be one of the absolute foundations of my work.
In what sense?
Well, I think it actually, in actually the techniques that I was exposed to, allowed me to start to build a whole range of insights into people and characteristics of place. So after the graduating in the psychology area, I ended up traveling for a couple of years around the world, and then came back, did an MBA, and started working in business marketing. And funnily enough, then found a job that was looking for someone with psych honours, MBA, 2 to 3 year sales marketing experience.
Did they write the job description for you, David?
That's how it felt like. Well, I only applied for it because it was so specific and I met every criteria. And it turned out to be a UK-based company that about 10 years earlier had pioneered for financial services the shift from bank managers approving loans to automated scorecards, which is now the fundamental for finance around the Western world. And in addition to the work that they were doing on predicting whether a person would pay back a loan or not, the risk there, they started looking at the marketing risk. And so they had another section of the business that was building information around people and neighbourhoods and the characteristics of what would people buy, what was their capacity to spend, and what was the likelihood that they would actually pay for the goods that they had.
So how do you actually start to build some predictions around that? What are you actually trying to put together so that you've got some way of predicting those things?
I think this is, if I use the technical term, it's unsupervised learning. So we don't have...
And what does that mean?
What it means is we don't have a particular outcome that we're trying to actually predict. So we're saying
it's not like the sort of more traditional research model where you've got a hypothesis that you're working from, or you do still have a
This is pre-hypothesis.
Yeah. And sorry, I know I'm asking lots of questions here, but do you think that this is potentially more similar to the real world, that's why you use it? And, is this something that potentially starts to give you much more in-depth understanding of what's going on in the real world?
I think the answer to that is yes, but there's also a second key thing, and that is you're looking for an organising principle or a set of organising principles in which you can actually have a lot of data with different variants, but you don't get drowned in complexity.
Yes.
So you're trying to find particular patterns that will be useful that can then be used as predictors of other events. So this really is a form of clustering to actually say, if we have all of the Australian population with different ages, different incomes, different kinds of houses they live in, different ancestry, what are the patterns that are here that actually define people and neighbourhoods?
And in a sense, it makes me think straight away of the question, well, are there patterns? And I'm sure you'll be able to elucidate that there probably are. And if so, how accurate are they? Because are we basically very predictable as humans, even though we think that we're so always, very unique and that we're, people can't tell what we're going to do?
I think the answer to it is there are absolutely patterns. And if I think about applications in the health area, One of the things that we built was a pattern of Australian neighbourhoods, which we called segments of Australia. And with that, that effectively was taking the Australian Bureau of Stats geography at which they released the data, statistical area 1, and actually identifying which kind of neighbourhood that was. Because we had that link between where people live and these characteristics, we were able to glue together all sorts of data. So we did some things, for example, with a range of the companies involved in health data. So we could look at data, for example, of scripts that were written for different kinds of things. So one of them was for tobacco or smoking cessation products. Yep. What was really interesting was when we actually looked at the profile and of people who were smokers, the likelihood of a doctor actually writing out a script for a pharmaceutical to help people stop smoking was significantly less if a person had a high socioeconomic status.
And why is that? What did you glean from the information that came out of that?
That maybe the doctors were more comfortable bossing around people who they felt didn't have that level of articulation or education, but that they were more intimidated by professional people.
It's an interesting discussion that you had on that, because it starts to get into the area of how decision making within the healthcare setting, and particularly one of the topics that Jack and I are really interested in is the biases that experts have. And obviously, physicians and medical people would be considered experts maybe in the area, and how over time we actually increase the number of biases that we have rather than reduce them. And so decision making generally at times, and our predictive capability often gets worse as we get more experienced, which you would hope that it was the other way around, but the evidence suggests otherwise. And with that in mind, it makes me think of, okay, well, what are the biases that are, as you're saying, like potentially changing someone's approach to someone from a different socioeconomic background? Do you think that there are ways around that kind of behavior, occurring, say, in a medical setting? Are there things that went out as directives from what you actually did in your studies?
Look, I think there's a really interesting case study, and that is in the 1980s in West Australia, a couple of doctors actually identified that stomach ulcers were caused by bacteria, and that it was possible to treat them with antibiotics. They got the Nobel Prize for it. 30 years after they got the Nobel Prize, 50% of people who are presenting for the stomach ulcers were not being prescribed their treatment. So that
just doesn't make any sense, does it?
Well, it does, in the sense of what that is saying is people learnt at a particular point in time and their knowledge got frozen. So one of the critical things is, how do you unlearn? And how do you actually get the confidence to unlearn? And I think that this is a real issue that we have. The second issue is that as we get more and more data in areas, we're actually getting more and more specialised. And so you get tunnel vision, and you're less likely to see the whole person, the whole issue, because you are so focused on a sub-area, particular thing.
Well, that seems to be a really big problem with specialisation across different domains, even, whether it's just dealing with one individual or even within that individual. We've spoken about that a little bit, and even in a discussion that we had, what you're saying makes me think of something in a discussion we had with a gentleman called Richard Newsham-West, who's head of the School of Physio at Lateral. And correct me if I'm wrong, because my modelling and statistics is obviously not very deep, but are you talking about using an understanding and approach that's sort of more Bayesian in focus, like where you're sort of using the data that comes in to update what you're thinking? Although obviously it might not necessarily be related to your model, but when you're actually, as an individual who's dealing with a problem, should we always be thinking about this concept of, as new information comes in, we should be moulding our position on what's going on?
Look, I think the short answer to that is yes. I think one of the challenges here is that when we talk about the how, We're not actually talking about the what or the why. So if we go back, for example, at the issue that I spoke of increased specialisation and therefore less connection with a person, less ability to see outside that area, and you start to say, well, why is that occurring and what can be done about it? So from 2006 to 2016 in Australia, when we look at the medical workforce, we flipped from 60% being generalists to and 40% being specialists to 60% being specialists and 40% being generalists.
And is there sort of economic drivers for that?
Exactly. And this is where you start to see that what on the surface, it doesn't appear at all. But the fact that the Medicare rebates have been capped for so many years has actually made it less economically attractive for medically trained people to function as GPs.
Yes, okay.
And so we're actually seeing here where government policy, which might be at a very high level, is not considering to what extent does this change the capacity of a person to diagnose, treat, manage people, can have a very insidious outcome.
Did you, I don't know if you've seen any of the books by David Epstein, but his second book is very interesting, and it's about the fact that generalists tend to be the people who solve bigger problems because they draw on information from lots of areas. And it makes me think of you and what you do. Do you think the fact that you actually approach big, complex problems, that have multiple, inputs and get practice sort of working in this environment, do you think that you actually develop the skill of being able to see things across a much more general viewpoint? Is that sort of something that we should be aspiring to do, is actually explore problems that require us to think outside our specialized area?
I think absolutely. And that's why a lot of people are quite reductionist, and they look at what skills we need in Australia and we say, we need science, technology, engineering, go for STEM. We don't need STEM, we need STEAM. We need the arts in there.
Yeah.
Because unless you can actually work out the why and things, if you just focus on the how, you're getting nowhere.
You don't get there, do you? And I think that's interesting that you straight away said that you felt like the psychology was a big influence on the way, not only probably your statistical thinking, but about people. Obviously, when we're dealing with people, that's relevant, but it makes me think a lot about, my background is as a clinician, but also as a coach. And to me, as time goes on, as the nitty-gritty technical parts of understanding how to make someone, say, run faster is becoming less and less. So it's not that it's becoming less relevant, but it's becoming less of the challenge. And the more interesting challenge to me is how to create the, psycho-emotional environment that creates the best performance. And I think it'd be interesting to hear your insights into how that's influenced your ability to see these, large population problems from a, psychological and motivational point of view.
I think you've actually hit on something that's right at the heart of probably why governments fail at the moment. And I can just give you an example. If you look at all of the money that is thrown into really try and change domestic violence. Now, domestic violence is a really serious issue. It's not saying don't put money into it, but the approach that is being adopted has come out of a traditional policing approach, forensic analysis, get the data that can stand up in court to actually prosecute someone. If you actually start to think about the experience of people or those people who experience domestic violence, you can start to actually explore how many of those never actually get support or help. What are the ways in which you could actually redesign elements to provide better support for people? So you shift it really to a preventative approach rather than...
that makes a lot of sense. And like for those people who've read Malcolm Gladwell's book, Talking with Strangers, he talks about this concept with police and policing in certain states in the US and how they had a huge change in the way in which people in a certain area and the amount of crime that was happening in a notorious sort of part of, I can't remember which city it was, but a notorious part of the US. And what they did was exactly that. They started changing the relationship that the police had with the community. It wasn't we're here to tell you off. It wasn't we're here when things go wrong. we're here to be support structures for this community. It makes me think exactly what you're saying, that if we start creating support structures before we end up in a position where domestic violence becomes the reality, it takes away that need for it to, deal with it after the problem's already occurred.
And what we know is that if we don't change our thinking, the range of problems and issues is going to be exponentially worse over the next 10 to 20 years.
Is there data in that can show, I'm sure there is, we always talk about it in healthcare, it's much better to prevent, say, for us, it's an injury, but in other parts of healthcare, you'd much rather reduce the opportunity for an illness to even occur in the first place. How well can you model those things, and how well can you show the preventative side, whether it's domestic violence or whether it's, say, the prevalence of cancer or something like that? Can you actually model those things to a reasonable level of accuracy?
The answer to that is yes, and it comes into, I guess, there are a number of hows to do that. One of them is actually using Bayesian probability approaches, decision trees. Yep. And essentially what you are doing is you've got a conditional probability. Yep. How likely is it that such and such will occur? Yep. And the stronger the model, you're effectively getting all of your if this and that, then the likelihood is this. Yep. So absolutely, those techniques work very well. They vary according to the actual problem you're trying to solve.
Yeah, of course, because obviously the prevalence will be different and risk factors might be different across different populations or illness types. Yeah, makes sense.
And I think just following on from that, the worst approach I think you can have is a black box approach of throw something in there. Because if we look at a lot of health conditions, a number of them where you've got chronic conditions, they'll tend to appear at later stages in life. So therefore, the single most explanatory predictor for will you actually have this condition or this injury or something is age. And so the smart thing to do is
not get old.
Well, I think the smart thing from a modelling point of view is actually say how much can be explained by age, then just remove that totally from the picture and say there's a residual that hasn't been explained.
And what are the modifiable risk factors?
Exactly,
Oh, you go down David Sinclair's research. You don't have to get old. Have you seen any of that, David?
No.
He's a researcher.
Essentially, they look at age as a disease.
Yeah, he sees it more as a disease, rather than specifically being the normal process of getting older.
Let's see how that unfolds. Yeah. But it seems that, on that note, it seems that a lot of people are speculating that in the next 10 years even, we'll see lifespans increase 20, 30 years.
Well, his prediction, and obviously he's open to the suggestion that it may not be correct, but that lifespans between 120 and 150 years will become normal.
But you then counter that with things coming back to our failure to have a preventative approach. So if we look at the antimicrobial resistance and the issues there, essentially the shelf life that we've got for our existing antibiotics is limited. And we know that the likelihood, if we continue on our current trajectory, within about 15 years, you'll have at least 10 million people a year dying from bacterial infections, at least. In the US, where that will come through is that you will have all of the contaminated chicken that people are consuming will actually build up within the body E. coli that are resistant to the bacteria, that are resistant to the treatment. The challenge there is, particularly for women, that if they get a urinary tract infection, it'll turn to sepsis. So we're going to have massive issues here because of the way in which we're...
And what are the potential solutions to things like this?
Well, this is where it comes to actually having a multiple perspectives. It's not just one thing. You've got to look at how are the actual factors here involved in the creation of all of these mutants. And so we know, for example, that when you have sewage from intensive farming, that in the sewage ponds, you actually have high levels of high rates of heavy metal, which act as catalysts to actually increase the rate of mutation. So that we're actually, in our water systems, we've got to have smarter ways of actually managing
Like water
sewerage and
filtration.
water.
Yeah.
And it's a global problem because if you have in China a super intensive piggery and you've got the sewage pond there, the birds that actually land in the sewage pond fly down to Australia and they'll land in Werribee. So we're not immune from what happens in other countries in the world. So this is something that actually requires global approaches around animal husbandry, around water management, and around the use of antibiotics in treatment of people.
This makes me think a lot about, you mentioned about governments before, and do you have a level of optimism that there is going to be coordination between these different parties? Because to me, that seems like the biggest challenge is getting people to work together.
But do you think the solutions will be solved by government or solved by, well, problem is likely tech?
Potentially tech, but the question becomes is that needs to be implemented. And the thing the governments always have the opportunity to do is create widespread change quickly, right?
Yeah.
Otherwise, it needs to be so overwhelmingly economically viable that companies will just do it no matter what. The problem that you always have in these areas, and David probably knows more and he can correct me, but it always seems to be that if you want massive change, particularly in agriculture or environmental policy, it needs to, as I said, either be so economically viable for the companies that it's so much cheaper and more efficient for them to use that new technology, or the government needs to step in and say, no, like you need to use this now, even though it's too expensive for you to go and do so off your back. And they create obviously incentive schemes for them to do so potentially, but it seems like that's the balance.
Yeah, and I think it's probably even worth asking more specifically, like when you think about some of the healthcare issues that we're facing, particularly, well, not just in developed societies, but generally speaking, where so many conditions that we have are chronic diseases in nature that typically tend to be this gradual insidious onset. And like we can even think about this within our profession where, most problems that people present with are not typically traumatic in nature. But where do you think you start in terms of creating changes, I don't know, probably from a top-down level, I'm assuming, to address some of the chronic disease burdens that we're seeing within our society?
I think a good friend of mine and business partner developed what he called the ABCD model. And the ABCD model was basically say you start with A, where are you now? And what are the key things that are actually holding you back at the moment? So before you rush to a solution, you actually try and work out what are all of the complexities about where we are. The B space of where do you want to be is something that should be possible but not probable. So you've got to give yourself a stretch. The C is then, well, how do you get there? And D is how do you measure your approach there? What happens is people typically jump to, we want to change this, go to the B space. They haven't explored the actual A space at the moment. So therefore their hypotheses actually end up not actually delivering, and you just get that whole quagmire and everything going on.
Go, Jay.
I was actually going to ask something that you were mentioning before we started recording. I think it'd be good to explain is the process of problem solving of using a supervised versus an unsupervised approach. Could you explain that? Because I think that's something that's really relevant to a lot of the issues that we're seeing in healthcare.
Sure. And I think the idea of supervised learning is that you've already got a known outcome. And a known outcome could be, I can accurately diagnose you have heart disease or you don't, right? So the idea about I can assess something and put you into a bucket.
And essentially use heuristics.
Well, the how is separate, but the critical thing is you've got outcomes that can be defined clearly. Unsupervised learning is really about, I've got all of this data, all of these things, and I'm trying to actually see out the key patterns that exist here so that those patterns I can then start to say, well, there's something going on that is grouping these people together, then what is it about, the things that I can see here that then start to give me better insight into either the experience of life they've had or other things, which will let me then develop hypotheses for the future.
Yeah, I think that's really important because for the people that are maybe listening more as individual clinicians or even in sports performance, like I always think that those emerging patterns or those emerging behaviors that you see are the things that you typically are measuring. But often we, as David said, we're using the wrong end of the learning process. We're saying we think that there's already an outcome that we're expecting.
Yes.
And I think we spoke about, and we haven't released it yet, but we spoke about periodization and how people have this predetermined idea of what the outcome's going to be. Therefore, they manipulate all the training loads rather than actually just measuring what comes out and then changing what inputs they have based on what comes out, rather than just saying, no, I think that they're going to be this amount of fatigue here, and therefore I'm going to change their training program before that even happens. And I think that that's one of the key things that's an issue we've discussed a lot, David, how people in healthcare, they'll use, practice guidelines or clinical guidelines that are typically protocol driven. And they even have timelines are set with them, but they don't necessarily take into account what's coming back from the patient. The patient might be reporting something very different to the typical, protocol, yet they'll move on to the next stage because, it's been 4 weeks of whatever input, whatever treatment, whatever medication, we're going to go to the next stage, rather than listening, as you said, to what patterns coming out and saying, oh, wait, no, the patient's actually responding really differently. They're ahead of schedule. They're behind schedule. We maybe need to manipulate what we're doing here. They jump straight away to, no, the protocol was this. And to me, it makes me think of that idea of supervised versus unsupervised, even though it's different.
But it's similar in a way. And I think this is, well, at least from my perspective, getting to the crux of some of the problems we see within our profession, but I think it probably extends to healthcare in general, is we can obviously use certain heuristics to identify particular problems. Like we use them all the time clinically. You come in, you've had an incident where you felt a pop in your hamstring sprinting. It's quite likely going to be a hamstring strain. It's not a very difficult process. But even once you reach the outcome of knowing what the problem is, or a lot of the time you may not know because it may be more non-specific in nature, what do you do with that information then? I think that's one of the big problems that we face within our profession, at least, is we're still expecting to follow some algorithm or some specific protocol or method in order to get them to solve the problem.
And I think one of the things I'd like to ask David based off that is something that we've really wrestled with is trying to get across to people of how to be more comfortable with the uncertainty of knowing exactly what patterns are going to emerge. Obviously, clearly what you do is you go investigating patterns that you don't have any certainty at all about what's going to emerge. Is that something that you think is inherent just because that's what you do in terms of your investigations and your models? Or do you think it's actually a particular mindset that you need to apply, obviously professionally, but to be comfortable knowing that what you're going to get back, you actually don't have a lot of predictability about?
I actually think it's a cultural issue, and the cultural issue comes back to the way in which, for example, the services are provided are remunerated, and specification of what you do, when you do it, and so that the health insurance funds will look for particular patterns. So all of those things are really driving a conservatism of behaviour. I think just there's one other thing that is really important when you're talking about the issues here about, I guess, having the comfort to step outside a standardised treatment thing. The second thing is continuity of care. And this is an issue right across healthcare where if you don't have continuity of care, you won't pick up the signals. You won't pick up those elements. And where we can have the highest tech in the world, unless you've got someone who's willing maybe to hold a patient's hand in bed and connect with them, right, then you're not actually providing the care and service. So coming back to how do you put the humanity back into here, a critical element is not starting off with data, not starting off with things, but actual connection with people. That connection is something that is going to empower you to better understand maybe the kinds of treatment they can tolerate, the issues there, and give them the trust and confidence to actually let you trial different ways of dealing with their problem. If you don't establish that, then it's just a factory kind of process.
Has that developed for you from your experiences now working in, this data management and data modeling, or has it come more from your history in psychology?
It's really from all areas, but I think I've been really fortunate in the past few years to work with people on the leading edge of knowledge design and actually how to actually better understand the customer experience and to really start to shape your way of thinking around things. Because if you want to make a change, you've got to have three voices around. You've got to have the voice of experience. So you've got to actually have an understanding of what people are going through. And then you've got to have the voice of intent. You've got to have someone who wants to do something about it. And third, you've got to have the voice of design. So you've got to actually have a framework in which you can actually think about what you can do differently. So these techniques that we're talking about maybe trying things, they're all the how. They all come under the voice of design, and there's a need to build that out. But you need to also build out the empathy with that experience side of things, and you need to be able to get the permission of others to actually invest in what you're doing. Because if you go off as a bleeding heart doing something on the side and you're not being remunerated, then it's not going to work. So we're talking about how do you actually create in people who are coming into a profession and those who've got positions of responsibility in profession, how do you get them to light those three fires and to actually have a passion to do something?
Do you think that that's an issue related to kind of the preferences and personalities that are drawn to different professions? Because I know that if you look at, say, psychological research on personality, you'll see that, and it does vary obviously, but people who tend to be more interested in, say, the technicalities of things tend to score very low on things like empathy, right? So how do you actually get those to mix and match? If they're going to be really technically strong, how do you also give them those skills to be able to converse and be, someone that can engage at that level to get the right kind of interaction with the patient?
I think the answer to that,
it seems like it's the surgical problem.
Yep.
We always I say this, but funnily enough, often we'll get people who go see a surgeon and you say, oh, they're a great surgeon, good outcomes. They come back and they go, it's usually a male, and they go, geez, bedside manner was terrible, right? And you go, well, yeah, they're a surgeon.
Yep. And I think that there are some actually quite promising signs on the horizon here. And funnily enough, it's actually a massive transformation that will occur over the next 10 to 15 years. And it's the next industrial revolution. And this next industrial revolution is one where we actually have digital twins that create a replica of the world. And these digital twins, I'll give you an example here. At Deakin University over the past few years, there was a researcher who was part-time CFA fire captain and knew that there were issues about how to actually train people to experience hot fires. So he developed virtual firefighting techniques. And these virtual firefighting techniques have things like haptic
technology, yes, you can experience it, yeah.
He's now sold that to the US Navy, to most of the military forces in Europe. And the whole element about this is through the virtualization in something that is so real, you're able to actually get your feedback and to manage it. So for the surgeon, the idea about having elements where they can operate in the sense as if they were operating on a real person.
Yeah, and they get that experience.
But getting the feedback about their manner and other things as well becomes possible because you've actually got the ability to
almost step back and view it. That's interesting.
The other thing that really stands out to me, though, David, is the approach that you take is initially it's a qualitative approach. You're trying to understand the story and the experiences of the people associated with the problem that you're trying to solve. And from that, you're then starting to think about, well, what kind of data do we need to collect and how do we collect it? And I feel like, well, actually, if you think about the whole research process, it's meant to be based on people working in the real world situation, observing particular patterns, creating theories that then are tested in a research setting. But I feel like that's often missed a lot, particularly in, like I say, again, in our profession, where you may have researchers who have their own idea about how a problem should be solved and go about doing it. And so I was actually interested, like, what has led you to following that kind of approach of being more broad and holistic of, I want to understand the problem and actually talk to the people involved in this problem, then think about what we need to collect, as opposed to
you're just going forward and collecting it.
Always just being quantitative in nature, essentially. Yeah.
I think serendipity is probably the best way to describe that. I don't think there's any higher plan. It just sort of has emerged and come through. And I think what we're talking about here as well is something that universities are actually not set up at all well for contributing to the needs of professions into the future. And I say that if you actually think about the key roles that universities have at the moment is, one, give you skills in terms of current knowledge base and to actually do something. The second is research. And there is this implied hope that this research is going to translate into better outcomes and things for people. The reason it won't work is that there's actually a real failure to understand how knowledge is actually consumed as a product, right? Because knowledge, when you're actually finding research, if you're going to consume that in a product, then the funny thing is you've got to do exactly the same approach, working through how to generate the knowledge as the private equity companies do when they're actually investing in tech startups and everything. Because there's only really three things that they're looking for when you've actually started to explore. So the first thing is there a set of problems that haven't actually got a solution to at the moment? So what's the white space, the area where we could actually have something? So you've got clarity on that. Then you've got to be able to say, well, is it actually technically feasible to do something about it? Is it viable, as in how much resources are going to actually take to do that? And is there a demand for it? So you start to look at that in terms of an element. And this could be, for example, and let's say there's a new physiotherapy approach to something. So, does it actually, is it possible to create this virtual element that's going to be a training thing? And technically can be done? And second,
as soon as you say that, David, I start thinking about how in healthcare, and particularly in physiotherapy, which I think is probably a huge frustration to clinicians that do exercise some level of critical thinking, is often you'll have researchers, sometimes with very minimal clinical backgrounds, who will say, we found this and we tested it with a certain population, and then they try and ram that approach down your throat, say this is the best approach, and this is the approach you should take, and it's the most the evidence supports it, even though it's really clear that, as you're suggesting, there's another way of actually trying to gain that knowledge, and no one asked for that solution, but you're trying to jam it down our throat. And
it also brings into question, again, I know we talked about this briefly off air, the way that you go about approaching a problem is understand what the problem is and also collect data in the real world setting, which is a far cry from how a lot of research is done in universities, where you have this very controlled, restrictive setting that isn't reflective of what happens in the real world, nor does it allow you to capture the fact that you may not just be trying to address one factor within the problem. You might identify several factors or modulators, which then allows you typically to get better outcomes because you realize that it's multifactorial in nature. It'd be interesting to hear, what are your thoughts about that controlled trial
more
approach.
traditional research approach. Is there particularly in healthcare research, and if you guys are looking much more at a larger population sample, is there a little bit of a competition between the two types of the way in which knowledge is being gained?
I think there's a role for both. And I think particularly when you're talking about new drugs and technology, you want to have this controlled environment. And so that's the kind of standard things that you will actually want to do. So all the double blind, etc. things, right? Absolutely critical. But there's another element, which is actually understanding and getting better insight into really the factors over which you can have some influence and the factors that you don't. And if you are really smart in your model building, rather than actually having all of the data just thrown in to you building your model, you actually restrict yourself first to data over which you have no control. So you can't control a person's age, you can't control their sex, etc. So by just holding out and only using the things over which you can't influence, you get to a certain point of this amount of predictability. Then you start to introduce the elements which...
Is that a particular approach? Like, is that...
it's one which I guess, I don't think it's articulated in literature, but it's one that is common sense. But the second thing is...
common sense too, David.
It actually gives you segments, because if you actually have a whole group and then you're able to say, these are the actual factors over which I've got no control, and now, so here's an older group, here's a younger group, for example, and they've got different rates of the actual thing occurring. By doing that, you're then able to get a more nuanced element about when you do have things you can control, they're playing out within a subpopulation, so that the idea about you're actually getting closer to a better understanding of things. And ideally, the higher the prediction that you can get, the higher the probability of assessment of outcomes, the stronger your model is. Now, none of these things are ever simple, right? And when you start talking about probability, this, I can think back to a totally different world, which was around the financial modelling of that company I spoke of at the start, when they're trying to predict, will a person actually pay back a credit card or a loan? So that kind of element, actually then you start to look at that and say, well, how far in advance of that behaviour do I want to predict? Do I want to predict the day that it happens? Do I want to predict 1 month, 2 months, 3 months before? So now what you have to start looking at is, if you've got in a health world, how far in advance do I want to be able to predict? Because the further the time period and you withhold data, the weaker the model. But the flip side is that the more powerful the intervention is.
Of course, yeah.
Yep. So you need to be able to actually work out what's the actual trade-offs.
I guess the hard part then is, and this is, I think, a problem that younger people face, is it's almost impossible to drive behavioural change when the development of, say, an illness is 30 years away.
Yep.
They just, it seems like the motivation to do so is going to be low.
And particularly with the human behaviour, typically you expect you're never going to get old or you're never going to get unwell until it eventually happens.
Yep. But having said that, there's been significant changes in rates of smoking.
Yeah.
So I think
do you think this is interesting to me, because I see a parallel between, say, smoking and, say, the climate change movement, where I talk with people who are very much, I would say, almost climate activists, and I have arguments with them, right? Because I'm not in any way arguing that we don't need to act and we don't need to act quickly, but they argue that it's sort of the individual responsibility of people in the community to do something about it. And very much like smoking, I think most of the changes happen from policy rather than from individuals all banding together and saying, oh, we're going to stop smoking, we're going to encourage other people to stop smoking. I don't think that's what happened. I think the governments realized that it was important. They started restricting the amount of advertisement. They started giving out much more clear health information. The medical profession actually started giving proper health advice around smoking rather than encouraging people to smoke, which was happening, I think, not that long ago. I just think that observation to me is interesting, because I think the same thing probably needs to happen at a government level for major changes to happen within the climate movement.
The other thing I'd be interested to hear from your experiences, David, because I know a lot of your work has been influenced in changing policies, whether it's related to health or say like public transport or whatever it may be, is people who are making policies, are they more interested in the kind of data and approach that you take, or are they more interested in the kind of more, you may consider it to be like that rigorous approach of that more controlled type of setting? Like I'm thinking of, say, like with healthcare policies, are they more interested in trying to get experts to talk on what all the most recent and best RCTs are in terms of treating a particular problem? Are they more interested in sort of this more nuanced approach of collecting big data and seeing the multivariate nature of a problem?
I think there's enormous appetite and interest in the more complex and big data approach. And
is that because it's currently sort of seen as a bit sexy?
No, I think it's because they've hit limits in other areas, right? And the second thing is that if you want to go down the path of the controlled side of things, you have to, and quite rightly, go through very stringent ethics.
Yeah, well,
and those ethics approvals can be 1, 2, 3 years to get through. And so all of those elements actually slow down the things, so that the idea here is, if we start off and say ethics approval is critical and we need to have the right ethics, when you start to de-identify data, and rather than actually analyse an individual, you start to use mathematical techniques that allow you to work with small groups, then you can overcome the issues of privacy. And at the flip, you can actually now start to build real insights into the characteristics that are associated with particular outcomes.
That makes me think, in preparation for this, I actually posed the idea of, how does ethics fit into the way you actually even put together these models? Can you give us a bit of an indication of the ethical considerations that you actually have, whether that's an industry thing or even just you personally, how you view that? Because at a certain level, if policy is going to be driven from the modeling that you do, I'm sure, knowing who you are and a bit about you, that you're consistently probably thinking, well, what's the ramifications of what I'm going to end up maybe giving insight to?
It's interesting, because I think one of the areas which I guess had the clearest impact in terms of policy was analysis that I did on drink driving in Victoria, and being able to actually, through analysis of all those people who'd been detected drink driving, identify the likelihood that people in particular geodemographic groups would be on the road under the influence of alcohol, and then looking at the rates of detection and the rates of the expected underlying behaviour. The result of that work actually identified that areas in the back streets of Geelong and Mornington Peninsula were
high risk,
and weren't being actually detected.
Yep.
And it was because of the porosity of the road network in Mornington Peninsula and things. But the TAC basically used that and then funded Victoria Police to actually solve those issues and bring them back. So I think that it's important to recognise that any of the work that's done can lead to impact in public policy, and it's important, therefore, to be open and transparent around what is being done, the approaches that have been done, because we're talking about likelihood. We're not talking about an absolute you will, you won't.
Well, it just these ideas started to make me think about some of the work that ended up happening, say, in like screening, and particularly in the area of, say, genetics. And I think we probably went down a path where we acted upon genetic predisposition too heavily before we even saw the prevalence increase in certain populations. And it just made me think about the fact that before you start making those recommendations, I'm sure you're consistently thinking about, well, where potentially does this end up?
I think, yeah, and it's very hard to actually identify where it will end up. So I think that's why it is actually important to be open and to actually allow people to see the work and to replicate and to understand the principles that are involved. And this is where I think that element about the nuance, and it's not black and white, you will get it, you won't get it, but if the likelihood is 3 times higher, then what are the opportunities to intervene and when? It's actually framing up a way of thinking for all of the health professions to adopt a much more preventative approach, but they actually need the science and the framework to actually allow that to occur.
Yeah, it's one of those things that I think it's clear that we don't necessarily get taught to think probabilistically, and it's a major problem because, as you said, you're not thinking, okay, what's the likelihood of this and what's the probability that I need to act on it before it becomes something of concern. So, yeah, I think you're highlighting some key areas that, as clinicians, we shouldn't necessarily be thinking very much about that as a black and white outcome. We should be much more thinking about how likely is this outcome. And I know that for those people who work in, say, return to sport and return to performance stuff, you're always constantly having conversations, whether it's with the athlete or the people involved, of, well, how confident are you of them coming back and not re-injuring? What percentage chance, what probability you're giving? And a lot of times I think you're going off a best guess estimation. However, I think it's important that we start developing some of those skills. Do you have in your sort of tool bag ways in which people can explore that if they're in, say, a clinical setting, how they actually start thinking through that? Is it something that you think comes relatively naturally, or do you think it's something that we actually need to practice?
Look, I think it's something you need to practice, and it's interesting because if I think back to some of the work we did with doctors some years ago, we found that where doctors actually had treated a condition regularly, they were comfortable actually recommending new or different treatments. Where they were only doing it infrequently, they would just go for the stock standard element. So I think what this actually says is there's a role for building expertise across a range of areas so that you can actually have the confidence to explore with the patients alternative ways of recovery and treatment.
Yeah, it's sort of one of those things, as you said, once you've got a level of understanding, something that's strong enough, you then feel a little bit more comfortable to step a little bit off the track.
Yeah.
Have you done any work of the other part of the equation I think of is not just about, say, changing skill or mindsets of, say, health professionals in this situation, but thinking about how we create behavioral changes in patients or people, because that's obviously the bigger part of the equation. And I mean, sometimes that's quite easy if it's, say, a technological solution where you're giving them pharmaceutical or some other type of intervention. But if it requires some type of lifestyle change,
behavioral change,
it can be very difficult.
So there's a whole field. There's a whole field of behavioral economics, and the idea about behavioral economics and nudge element. Unfortunately, it doesn't actually work all that well.
So forcing you right.
And when I say
this
that,
is China.
when I say that, a lot of the changes that have been attributed to, like, the nudge approach, actually comes down to pure awareness.
What do you mean by nudge approach?
So the nudge approach might be that if you don't do something, then you'll be fined. Right. So that these elements about you get a financial incentive or disincentive to do a particular behaviour, right? But often when you actually come back to it and you say, well, when people did change their behaviour, it's purely that nudge element made them aware of a need to do something rather than the stick or the carrot. So it's really important not to get caught up in sticks and carrots. And again, be as Occam's razor. First thing is, do they actually know that there is a program or something,
or a risk associated
with that?
And is that what you like? I didn't let you finish. I apologize, but when you're talking about, said the preventative programs for domestic violence. Is that what you mean, that there needs to be much more understanding and education around what can be done to prevent domestic violence? Because I think there's almost this, in some interesting way, it's almost that people just think, well, it's just part of society, is what happens within people's households. But it's clear that that's probably something that is not the mentality we should be taking.
Yeah, and I think if you look at domestic violence, it's got all of the classic data problems that you have trying to do something, because you've got underreporting people who weren't there, and then of those that report, it's only a subset, for example, with police or other things. Yeah. So what's the true incidence that goes on there? Now, you start to look at that, and if you just go to the standard approach with police data, you're really missing out on a vast majority of the hurt and the issue. In Victoria and in Tasmania, some years ago, Google actually sponsored a program to capture the notes of every ambulance crew and every trip they made. So there's actually data that sits there about domestic violence, the conditions, was the person intoxicated, was the assailant intoxicated, what were the injuries, etc. A vast amount of data that, if that is managed in the right ethical approach, can be used to actually build a better understanding of the incidence of these severe events of domestic violence, which will be a much richer, more accurate picture than anything that's here at the moment. That in turn can start to let you understand, well, what is the current situation and pattern before jumping to we need to do this or we need to do that. So get an understanding, find new ways to better get, the picture of what's there. But linked into that, the second thing that we looked at a couple of years ago and we weren't able to actually get it going was the federal government had started to use with its PBS data an understanding of the geographic catchments of all of the doctors in Australia. If you linked de-identified data of the people who have domestic violence issues, so their home location, right, to a statistical area, you link the doctor's statistical area, you're immediately at that point able to say which doctors actually have higher exposure rates to people with that. At what point should we potentially provide support services embedded in GP practices so that you're not having something of there is a risk, where are you going? I'm going to the family violence thing, whack, you're not, versus I'm going to see the doctor for something, so that the safe opportunity to see something and things. So it's actually how to get smarter around leveraging existing resources and making things work better.
Well, that's the thing I'm getting from what you're saying here, David, is you'd think particularly as technology becomes more and more embedded in everything we do, there's an opportunity to collect a lot more data points from just everyday interactions.
That already exist,
Yeah, and particularly as you can identify them. And that allows you to collect quite unique data as opposed to, again, I always just think from our perspective from a healthcare setting in that very controlled environment where you're only collecting data based on what you're specifically looking at. And you quite often will one, may not identify things that are relevant, or two, may not gather information that otherwise the patient
I think that it alleviates the major problem that David suggested multiple times, is that the information quality that you're receiving, if someone knows that you're collecting the information, particularly say like the police, or even if they know they're within a research study, is very different than if it's being collected in a real world environment.
It's unfiltered in that sense. Yeah, absolutely.
All right. I think we've touched on a lot of topics. It's been about an hour or so. Was there anything else that you wanted to bring forth, David, that you want to pass on some more of your knowledge?
Look, the only thing that I really try and do is encourage people to have a go, in the sense of don't accept the orthodoxy of everything that you're taught as a clinician. Have the ability to challenge, work with peers, and the confidence really to really connect with people, because that connection with people and their experience will actually give you the greatest opportunities for designing better therapeutic outcomes.
Very, very well put.
Yeah. I think it really just emphasizes that point of more often than not, you need to find nuanced solutions to most individual problems. You can't typically follow that one-size-fits-all approach.
Thank you very much, David, for joining us.
You're welcome.